This is Nurse 2212. This is Amber Knowlton. This information is going to cover medications related to asthma, and this comes from your text in chapter 29. So this picture here is also in your book. You don't have to memorize this picture, but it shows how the treatment of asthma goes into a step with patient education, environmental control, management of comorbidities. You step up if needed, and the goal is to step down with the treatment, with the medications that we're giving. The goal of drug therapy is you want persistent asthma, with drug therapy, with persistent asthma, patients require daily control. They have to be on medications daily. Quick relief or rescue medications for exacerbations would be examples such as your albuterol. And long-term control medications such as your inhaled corticosteroids would be a different type of drug therapy. So we're going to talk about all these different types. So the anti-inflammatory drugs, there's three types of anti-inflammatory drugs. There's the corticosteroids, the leukotriene modifiers, and the monoclonal antibody to IgE. Corticosteroids are used to treat chronic inflammation if it's a primary part of asthma. Inhaled corticosteroids are first-line therapy for patients with persistent asthma requiring steps 2 through 6 therapy, and this is that stair-step picture that I just showed you. Usually inhaled corticosteroids should be administered for 1 to 2 weeks before maximum therapeutic effect can be seen. Some inhaled corticosteroids, for example, fluticasone, budesonide, begin to have therapeutic effect within 24 hours. Inhaled steroids do not have significant systemic side effects that oral steroids do. Oropharyngeal candidus, hoarseness, and a dry cough are local side effects of inhaled steroids. These can be reduced, however, by using a spacer or by gargling after each use. And here's a picture of a spacer that's helpful in getting more medication also into the lungs. Here's a child using a spacer with a face mask. Also, under the anti-inflammatory drugs, the development of newer drugs, for example, cyclosinide, that are activated in the lungs, not the pharynx, appear to minimize the side effects without the need for rinsing the mouth or for the spacer. Also, women, especially postmenopausal women who have asthma and who use corticosteroids, should take adequate amounts of calcium and vitamin D and should participate in regular weight-bearing exercises. Okay, moving on to the leukotriene modifiers. Leukotrienes are inflammatory mediators. Leukotrienes are potent bronchoconstrictors, and some also cause airway edema and inflammation, thus contributing to the symptoms of asthma. Leukotriene modifiers have both bronchodilator and anti-inflammatory effects. They're not indicated for acute asthma attacks, and they're used for prophylactic and maintenance therapy. One advantage of leukotriene modifiers is that they are administered orally. They can successfully be used as add-on therapy to reduce, not a substitute for, but to reduce the doses of inhaled corticosteroids. And there's examples of these type of medications in your book on page 570, table 29.7. All right, the anti-IgE medications, omalizumab also known as Xolair, is a monoclonal antibody that decreases IgE levels, prevents the release of mediators. The drug is for moderate to persistent asthma. It's given subcutaneously every 2 to 4 weeks. There is a risk of anaphylaxis with this drug, and patients must receive the medication in a healthcare provider's office when this emergency can be handled. So we're going to talk about the 3 types of bronchodilators: beta-adrenergic agonists, methylxanthines, and anticholinergics. So the bronchodilators, these are known as your rescue meds. The short-acting beta-adrenergic agonists, the ones here on the screen right in front of you. So the example would be albuterol. These drugs are known as the rescue meds. These drugs act by stimulating beta-adrenergic receptors in the bronchiole. Thus, they produce bronchodilation. They also increase mucociliary clearance. Be alert, however, that you want to use caution in patients with cardiac disorders when you're using these short-acting beta-adrenergic agonists, because patients with cardiac disorders, they may cause an elevation in their blood pressure and their heart rate. So this can result in a central nervous system stimulation, excitability. They're at an increase for risk for dysrhythmias, both short-acting and long-acting beta-agonist medications. Beta-adrenergic agonists are also useful in preventing bronchospasms precipitated by exercise and other stimuli. If used frequently, inhaled beta-adrenergic agonists can produce tremors, anxiety, tachycardia, palpitations, nausea. Frequent use of these indicate that there is a poor asthma control, so that's a key indicator. Asking your patient, how often are you using your albuterol inhaler, your short-acting inhalers? And also by frequent use can lead to reduction in the effectiveness of the drug. So the goal is the asthma is controlled with long-acting meds, and that you shouldn't need to be using these short-acting inhalers. Long-acting beta-adrenergic agonist drugs are added and used as a daily dose of inhaled corticosteroids for long-term control. So for daily use, we have our daily inhaled corticosteroids and our long-acting beta-adrenergic agonist drugs. The long-acting should never be used as monotherapy for asthma, so they should never be used alone. They should only be used if the patient's also getting an inhaled corticosteroid. The advantage is they hopefully will decrease the use of the short-acting inhalers, and you always want to teach your patient that the short-acting inhalers are there to treat that sudden onset of wheezing. So the methylxanthines, these are used only as an alternative therapy for care in mild persistent asthma. It is a bronchodilator with mild anti-inflammatory effects, but the exact mechanism of action is unknown. The main problem with theophylline, which is one of the methylxanthines, is the relatively high incidence of interaction with other drugs and the occurrence of side effects, so nausea, headache, insomnia, GI distress, tachycardia, dysrhythmia, seizures. Also, you want to have the patient avoid caffeine because that can intensify the effect of this drug. Anticholinergic drugs, so an example would be ipratropium, which is also known as Atrovent. Anticholinergic drugs are used for quick relief in those patients that are unable to tolerate the short-acting beta-adrenergic medications. They're not as effective as those beta-adrenergic agonists either. They are used in anticholinergic drugs are used in an emergency and severe attacks when the short-acting beta-adrenergic agonist, let me start over there. Anticholinergic drugs are used in an emergency in severe attacks with a short-acting beta-adrenergic agonist. Otherwise, they really have no role in the treatment of asthma. The onset of action of ipratropium is slower than that of the albuterol, the beta-adrenergic agonist. So it peaks at 30 minutes to an hour and lasts up to 4 to 6 hours. So again, anticholinergic drugs are used for quick relief in patients that are unable to tolerate the short-acting beta-adrenergic agonist. Anticholinergic drugs should only be used in an emergency, and they really have no role in treating asthma unless they're combined, usually in combination with a bronchodilator. So the correct administration of drugs is a major factor in success. Inhalation of drugs is preferable to avoid those systemic effects that we talked about, especially with those steroids. Meter dose inhaler, the dry powdered inhaler nebulizers are devices used to inhale medications. So the meter dose inhaled is a pressurized device that delivers a measured dose of drug, usually with 1 or 2 puffs. A spacer is used to reduce the amount of drug delivered to the oropharynx and improve delivery to the lungs. One of the major problems with a meter dose drug is the potential for overuse. That's using them much more frequently than they're prescribed, rather than seeking medical care if they keep using them and using them. Dry powder inhalers are simpler to use. They're breath activated. There's no propellant. There's less manual dexterity needed. There's no coordination device puff with inhalation. There's easily visible color or a number that indicates when how many doses are left. There's no spacer needed. In your book on page 574, table 29.8 outlines the problems with meter dose inhalers. Table 29.9 talks about teaching on how to use the dry powder inhalers, and table 29.10 outlines the difference between the two. It's important that you do understand those tables and that you understand this information. This picture here is an example of a patient using a dry powder inhaler. Another delivery method for the asthma meds would be a nebulizer. The nebulizers are small machines that are used to convert the drug solution into a mist. Inhalation of the mist can be done through a face mask, a mouthpiece held between the teeth. They are usually used for severe asthma or for individuals who have difficulty with using the meter dose inhaler. The advantage of the nebulizer is they're easy to use. The patient should be upright to allow for efficient breathing, to allow those lungs to really open and penetrate the medication. And the patient must be able to breathe slowly.